Today I'll be sharing this interesting and difficult case in which there was a small eye, a shallow anterior chamber, an intumescent cataract which caused a Argentina flag sign, and there was a progressive conjunctival chemosis, and above all, the patient was little uncooperative. So here we have this cataract. The incision is being placed at the steep axis so as to neutralize the existing astigmatism, and we are also planning to give a clear corneal opposite incision so as to further control the astigmatism. We can appreciate the cataract is little intumescent and the chamber is very shallow. Trypan blue dye to stain the anterior capsule. Now at this moment when I started to inject the viscoelastic, I could appreciate that the chamber is not accommodating significant amount of viscoelastic, indicating that probably the chamber was extremely shallow. Proceeding for capsulorhexis, and the moment I made an incision using the capsulorhexis forceps, there was a rip, and this is what is known as Argentina flag sign due to the similarity between the Argentina flag and the picture which is produced. Looking at this at a slow motion, we can appreciate how this rip occurs, just like a balloon which is under tension. When it is pricked, it ruptures. So here we have a patient who also felt something in the eye and also started moving the eye here with it, trying to convert this rip into a rhexis. So making two nicks on the corresponding side of the rip. Now using a rhexis forceps to tear away this portion to create a circular opening. And in between these procedures, it was important to keep on filling up the chamber with viscoelastic. Otherwise, it is just not possible to proceed. The inferior flap has yet to be enlarged, and the approach was little difficult. So when I tried to enlarge this opening, I found that it had already extended to the periphery. So we need to make another nick in the capsule so as to complete the rhexis of the inferior flap. And we can see the patient is constantly moving the eye here and there. This adds to the difficulty and also prones the eye for any injury. A nick has been made in the capsule which has been flipped over itself. Using a rhexis forceps to complete this rip into a round opening. Now proceeding for phacoemulsification. The problem with these shallow chambers is that you have a small eye, a shallow chamber, and an intumescent cataract. So you tend to work close to the endothelium, which causes some amount of corneal decompensation, and the cornea shows the next day. I use a horizontal chop and a primary chop technique, and here we can appreciate that we will get the complete chop in first go, which is through and through on both the side, and this can be achieved if you are buried your phaco tip up to the core. Proceeding for dividing the heminucleus. It's important not to create too much of a stress on the zonules and the capsular bag, because it is already compromised and the rib can any time extend and cause a tear in the posterior capsule. Usually in these cases it is not important to cause a complete hydrodissection because the cortex is already liquefied and the capsulocortical adhesions are absent. Now once we have divided this nucleus into 4 pieces, proceeding for emulsification of the nucleus. We can also appreciate at this moment that there is a progressive chemosis which is occurring at the site of the main incision. This occurs because of an incision which is placed little towards the conjunctiva side. And this is also something which I have been forced to do, because being a small cornea, I didn't want to go into the corneal tissue too much, so as to start and still have a good length of the corneal tunnel, it's important to start little proximally towards the conjunctiva. A too much corneal incision will invariably result into corneal edema during the surgery and cause problem during the surgery, as the cornea gets opaque due to the edema. The nuclear emulsification is complete. And at this moment I suspected some amount of central PC tear. So I didn't pull out my infusion line, rather waited for the viscoelastic to be filled first, and then I pulled out my main incision instrument and the infusion. So there was a small tear which is not visible here. I didn't need to do any vitrectomy or any maneuver further because cortex has been cleaned. Implanting the intraocular lens inside the bag, taking care that it is not prolapsing through the PC tear and going straight into the bag equator. At this moment, because of the chemosis, nearly 360 degree of the conjunctiva around the cornea has swelled up, and this causes an issue that the cornea goes into a gutter, so as there is a collection of fluid above the cornea, and this behaves like a plane mirror reflecting light from the microscope and causing reflections and poor view. This makes the surgery difficult. Dialing the lens in the place, there's some amount of peripheral cortex which can be safely removed once the IOL has been implanted, which can hold back the posterior capsular opening. The annoying reflexes will cause some issue in the view, but if patience is kept and patient's head can be tilted away towards the same side where the surgery is being done, this will aid into the drainage. But still it becomes a little difficult task compared to a situation where there is no chemosis. Because there was a plan for opposite clear corneal incision, so now we will proceed for opposite clear corneal incision, which I prefer doing at this stage because the probe inside the eye provides me a very good index for the axis at which the incision is to be placed. Inflating the anterior chamber, which is a little easy task because of the abutting conjunctiva. Surgery has been done. This is the next day post-op picture. Thank you.